let's have a look. So we've got some people there already, which is great. Should we give like a minute, 2 minutes, something like that? And then
we'll give it a couple of minutes.
Yeah. So yeah, get yourself something cool to drink or whatever you like, really, wherever you are. Yeah. Yeah. Do you reckon we should make a start?
Yeah, we can start, and then whoever joins us,
yeah,
they can just pick up. So, welcome, guys, to another MedTech Thursdays. So, I'm Shantae. For those of you who don't know me, I'm also delivering part of the session on behalf of Aaron as well. He's also contributed as well, but unfortunately, he's unable to make it today. But luckily for us, Millie has also stepped in to offer some assistance with questions and polling and whatnot. So I think what we'll do, we'll just get cracking. Just like always, if you've got any questions, just pop them in the chat and try and engage with the polls. It doesn't matter if you get it right or wrong. We'll go through the explanations anyway. Okay, so today we'll be sort of going over some Obs and Gynae questions, and we're hoping to sort of cover topics around sort of the different learning outcomes here. So covering aspects from prenatal care, labour and delivery, so potentially complications and stages as well, postpartum care, monitoring and complications, some gynae cancers, menstrual disorders, and some other bits and bobs that we've also included as well. So what we'll do, we'll start with question one. I think from sort of feedback in the past, I'll just let you guys read it in your own time. We'll give you about 30 seconds and then we'll go through the answers. But yeah, feel free to choose an option in the poll as well. Okay, so the correct answer is answer D. So this question is sort of testing your knowledge about what tests can be applicable at what different stages. So we'll just sort of go through those in a bit more detail. So the correct answer was nuchal translucency with serum beta-HCG and PAP-A. So the NIPT, so the non-invasive prenatal testing, Although it is quite sensitive for sort of genetic disorders such as trisomy 21, it's not the first line screening test in the UK that the NHS offers. It's normally offered after high risk combined screening results or sort of when indicated, such as like advanced maternal age. B is incorrect because amniocentesis is an invasive diagnostics test not used for screening, and it's really only offered if screening shows a high risk or if it's done after 15 weeks gestation. And then CVS, so chronic villus sampling, it's an also invasive test. Sorry, it's also invasive, but it's used for diagnosis, not screening, and that's done from 11 weeks. But it's not really first line treatment unless there's kind of, a high known risk factor, like a previous trisomy pregnancy, for example. And then the quadruple test, it's really only done if the woman sort of books late after 14 weeks, and it's also less accurate than the combined test and sort of used as a backup. So it's not the first choice within the first 12 weeks. Okay, so moving on. Question 2. So yeah, we'll give you 30 seconds. Okay. So the correct answer is option C. So the next appropriate management step is endometrial biopsy. We'll sort of go through quickly why the other answers are also incorrect and a bit more about endometrial cancer as well. So option A, which was start progesterone therapy, I'll quickly click back, was incorrect because it's not appropriate before we establish a definitive diagnosis. So we have to exclude malignancy first. Cervical smear is incorrect as it's used as a screening test for cervical cancer. So it's not looking at endometrial pathologies. And as we can tell, sort of the key facts of, or the key red flag we look at for postmenopausal bleeding, we know that's a high risk for endometrial cancer. D, CA125, that's useful for ovarian cancer, but it's not the first line sort of diagnostics test for endometrial. And then pelvic MRI, so that can be useful sort of more for staging purposes, but again, it's not the first line investigation, and diagnosis is sort of imperative for, biopsy is imperative for diagnosis. So generally, if there's a thickness of around 6 millimeters or more, that's when we're looking to biopsy the endometrium. So endometrial cancer is the most common gynae cancer in the UK. It typically affects postmenopausal women. So again, that sort of key phrase, a postmenopausal woman comes in with unexplained PR bleeding, that's a red flag and should be ringing bells. And the majority of these cancers are estrogen dependent. So risk factors include sort of common comorbidities, obesity, diabetes, but it's also women who have an increased sort of risk factor as well of those who have hormonal insufficiencies such as PCOS, those who might have potentially used sort of anti-cancer therapies such as tamoxifen or HRT for hormonal control. So, if you've got a woman who's come in and they were previously breast cancer, they've had a previous history of breast cancer, it's always important to ask if they're on any sort of anti-cancer medication following their initial diagnosis. women who haven't had any children, but also at the opposite end, women who have started, or young girls who have started their periods early, and also late menopause, and then Lynch syndrome. And again, most common postmenopausal bleeding. A lot of women might also experience some pelvic pain or change in their discharge. Or, for instance, if they're still having their cervical smears and they experience some bleeding, that could also be a sort of something to sort of be aware of as well. And again, investigations, so endometrial thickness. So different texts will say 4 millimeters. I've was always taught as 6 millimeters, to sort of be aware of as to when to offer sort of on transvaginal ultrasound, when to offer a biopsy. And you can also do a hysteroscopy as well, so sort of refer to gynae that way. Management, so most likely it's the for stage 1 total hysterectomy with the bilateral salpingo-oophorectomy, and then management can change as well depending on if radio or chemo is required, depending on the stages. But yeah, well done for those who got C. So question 3, we'll give you 30 seconds as well. Okay. Anybody else? Okay, so the correct answer is well, what is it? Choice B. So answer B. So we want to offer an instrumental delivery. So there are kind of two key sort of reasons as to why this is the correct answer. So we've got a CTG, which shows a fast fetal heart rate, so potentially indicating that we've got some fetal distress. And then we've also got a woman who's been in active labour, or well, fully dilated for the past 3 hours, but then has been pushing for the last 2 of those hours as well, with no descent of the fetal head, which is again potentially indicating that the woman's at risk of becoming tired. And then we've also got the increased risk of sort of fetal distress as well. So I'll just move on. Oh, where have I gone to? Okay, so in terms of as to why the other options weren't appropriate as well. So if we wanted, which was question A, if we wanted the mum to continue pushing for a further 2 hours, it's kind of the accepted time frame of 2 hours is the maximum accepted window for women to sort of be pushing for without any progression. Waiting longer again just risks more complications for mum and baby. An immediate cesarean section, that's really only indicated if there's a failure of the instrumental delivery, or if it's not possible or potentially contraindicated. Administer oxytocin. It's not really indicated here, as mum's already fully dilated despite adequate pushing. And to perform an episiotomy, this can be done during an instrumental delivery if needed, but not as a standalone step as well, even though baby's not fully descended. So with instrumental deliveries, there are 2 types. We've got the forceps delivery and the vacuum extraction, and it's indicated mainly if there's a prolonged stage of labour, fetal distress, maternal exhaustion, or again like contraindications to pushing. And these can include incomplete cervical dilation, enlarged fetal head, and again, certain fetal conditions, bone fragility. But in those instances, anyway, if that was already picked up sort of during screening, it's more than likely, especially with like congenital bone disorders, that the mum would be having an elective cesarean section rather than being allowed or sort of it being recommended for her to go through with a vaginal delivery. So complications of an instrumental delivery. So there's trauma to the vagina and perineal area, also risk of hemorrhage, and then there's also potential trauma to baby, so like a scalp injury, a cephalohematoma, potentially even an intracranial hemorrhage, and specifically as well with forceps. If you imagine, as I'll show you on the next slide, the forceps come around the baby's cheek, so potentially could lead to like a facial nerve injury as well. So just sort of a photo showing you what I meant. So as you can see, baby's kind of still there, and the forceps are going all the way around. Can you see my pointer slide? Can you see my mouse?
No, I don't think
No, I've just realized. But you can see from the images. Okay, so next question. So question 4, we'll give you 30 seconds there. Okay, we'll just stop it there. So any more for the poll? No, we'll move on. So the correct answer is B, uterine atony or atony, however you want to pronounce it. So it's not A because that would typically cause, so it's not retained products of conception, because that would typically cause delayed or a secondary postpartum hemorrhage, so after 24 hours. And generally, the uterus may be firm or irregularly shaped, depending on how much sort of retained product is sort of still inside the uterus. Vaginal laceration. This causes bleeding with a firm uterus, and if the uterus is contracted, so think trauma rather than atony. And uterine rupture, so it's rare and it usually occurs in women who have had previous cesarean sections. And that's also accompanied with like signs of loss of fetal sort of station, or like the mum's unstable, and the uterus may not be palpable, or it may be particularly tender. And then coagulopathy, that's considered in kind of, persistent bleeding with no real sort of definitive cause, or DIC, like disseminated idiopathic coagulopathy, but it's less likely as the initial cause, immediately after birth. So uterine atony, so it's failure of the uterus to contract effectively after delivery, which can lead to a postpartum hemorrhage. So causes really sort of over distended uterus. For instance, if you've had multiple pregnancies or a particularly large baby, prolonged labor, or quite a rapid labor as well. So kind of, different ends of the spectrum. Sometimes as well can also be associated with use of uterine relaxants such as magnesium sulfate, previous surgery, like I mentioned with cesarean, or trauma, unfortunately, and potentially also some infections. So typically, you hear like heavy, like boggy uterus, some palpation, which often is indicated that the uterus still hasn't contracted. loads and loads of bleeding, with also accompanying potentially hypovolemia, so hypertension, and tachycardia as well from mum. So you want to immediately do a uterine massage, maybe consider some oxytocin, and also other drugs such as misoprostol. Ensure the bladder's empty as well. And if all else fails, very rarely, that's when they'll have to sort of decide about surgical interventions. So sort of the extreme aspect of that is potentially a hysterectomy, but that's quite rare in those circumstances. Okay, so question 5. We'll give you 30 seconds as well. Okay, so anyone for the poll? That's okay. So yes, for those who've answered E, that's correct. I can never pronounce I can never pronounce this, but I always say Mullerian agenesis syndrome is the correct answer. So we'll sort of go through this, why the other ones aren't aren't appropriate in more detail. So A is incorrect because that also presents with amenorrhea as well as an absent uterus, but you do have breast development. And that's generally from the peripheral aromatization of testosterone. And they'll also expect sort of absence of hair under the armpits and the pubic region as well. Turner syndrome, that can present with sort of, short stature, webbed neck, no breast development. However, the uterus is present. Hypothalamic amenorrhea, that causes suppression of GnRH, and that's often due to like stress or quite low body weight. But the uterus and vagina are both present, and there's no anatomical abnormalities or anomalies, sorry. So especially with C, that potentially could lead to, if you think of sort of the extreme, like a safeguarding issue, especially if you've got a teenager who is, very low weight. It might be sort of safeguarding from the parents' point of view, or potentially they might be sort of exhibiting sort of mental health issues at the moment. So that's something to be aware of if you think of OSCEs and sort of other considerations of what you might have to consider as well in terms of further advice. D, imperforate hymen. So there is a uterus, and the symptoms are cyclical, and you might often see a bulging hymen as well. The vagina is present, but it is obstructed. So that also might be accompanied with sort of pain around when they might be experiencing the time of the month. Okay, so Mullerian agenesis, it's a congenital absence of or underdevelopment of the uterus and the upper 2/3 of the vagina in females, but they do have normal ovarian function. So sort of key features, they have a normal external genitalia, normal secondary characteristics, breast development, pubic hair, but they have primary amenorrhea, so no periods, and the normal karyotype is XX. Other associated anomalies, so they might have renal anomalies, skeletal defects, so vertebral anomalies, and potentially hearing loss, but as you can see here, it's less common. Diagnosis, normally clinical exam and history. You might want to consider using an ultrasound or an MRI for a more detailed picture as well, and also a hormone profile. And then diagnosis as well. I've just repeated myself there. Okay, so next we'll go into question 6. So again, give you 30 seconds. Okay, so the correct answer is C, so increased exposure to insulin acting as a growth factor. So here, so the learning point really is macrosomia. So from gestational diabetes, it can lead to increased exposure to maternal glucose, which is able to cross the placental barrier. It increases sort of fetal expression and production of insulin, and then insulin then acts as a growth factor. So it's gestational diabetes. It's characterized as glucose intolerance during pregnancy. It's usually transient and can sort of disappear for most women, especially after delivery, but it can also be an indication that it can predispose them to developing type 2 diabetes in the future. And especially if a woman has sort of developed gestational diabetes in their first pregnancy, there's also an increased risk of them developing gestational diabetes in their subsequent pregnancies as well. So generally, most women aren't tested until sort of midway through their second trimester. However, if you've already had one instance of gestational diabetes, that can be picked up on booking and you can be tested a lot sooner as well. So I already sort of discussed the macrosomia mechanism. In terms of complications of women who are found to have gestational diabetes in terms of the risks during pregnancy. So it can increase the risk of shoulder dystocia and increase the risk of fetal neonatal hypoglycemia on birth. So as we can see here as well, we just got some diagnostic criteria. So if you've got a fasting glucose of a level greater than 5.6 or above, or if you've got a 2-hour plasma glucose level of 7.8 or above. Okay. So question 7, we'll just give you 30 seconds as well. Okay, so the correct answer for question 7 is C. Yeah, well done. So question 6 from 7 have been kindly sort of created from Aaron, and he's used some of his own sort of working experience to help create these questions. So this was sort of inspired from a case that he recently saw on his infectious diseases placement. So he kind of really wanted to highlight sort of the recognition and treatments of chlamydia. He, from his experience, sorry, he's just provided some information to sort of share with you guys. But he said he found it sort of the diagnosing of chlamydia and the testing fairly non-specific, and it is normally usually found on routine swab tests. But you should be aware of, because women might typically present with a typical symptom of change in discharge, or sort of a smell or an itch, but it can be a bit more difficult in men. They might also present with discharge, they might also not, but you should also suspect patients who might present with dysuria, but also again can be completely asymptomatic. So chlamydia is currently the most common STI around the world. Used to be sort of 20, 30 years ago, it used to be gonorrhea. The peak incidence age is sort of 15 to 24. So, really young adults, sort of first few years in university. Again, risk factors, the main one is unprotected sex, new sexual partners and multiple sexual partners. And again, look out for the key symptoms. You could have vaginal discharge or sort of other symptoms, but most people will be asymptomatic, or might present with some dysuria. So you might be thinking of a UTI, but it's also sort of important to ask, have you had any new sexual partners? When was the last time you got tested? And it's normally tested with the sort of NAT test, which Aaron's supplied a photo in the bottom left corner. And it's usually vulvovaginal for females, or endocervical as well. And in men, traditionally, again, going back 10, 15 years ago, you might have to insert a swab down the urethral meatus, but now you can also just test the urine as well. And it's pretty treatable. So just a course of oral doxycycline for at least 7 days. And then just like with any STI, it's also, really important just in terms of encouragement of getting the patient to sort of notify their sexual partner for further screening as well. Okay, so question 8. Okay, so the correct answer is A. So hypoperfusion to the pituitary gland due to an intrapartum blood loss. So also known as Sheehan's syndrome. So it's caused, so it results in secondary amenorrhea, and can be caused by several factors. But most women sort of notice or realize that they've not had a period sort of up to 6 months afterwards. A lot of women sort of follow the old wives' tale, especially if they're breastfeeding. That's, breastfeeding can potentially delay you sort of delay your periods going back into a normal cycle. So a lot of women tend to not sort of think too much of it. But for some women as well, if they potentially had so blood loss during pregnancy, that can lead to hyperperfusion of the pituitary gland. It can also result in sort of severe necrosis or severe pituitary dysfunction afterwards. To be fair, in the UK and sort of Western countries, it's relatively rare because of the availability of blood and getting that blood back into the women to obviously kind of promote reperfusion. But it's important to be able to spot and manage. So signs, again, are mainly related the fact that the woman hasn't had a period despite not being on any sort of hormonal contraception. And in order to sort of diagnose or in order to diagnose what's going on, generally it's an MRI of the head to be investigating the pituitary. The effects, as we can see here, can lead to a decreased secretion of FSH and LH, as well as prolactin as well. So women might come in, they're 6-7 months down the line and they're still experiencing difficulty breastfeeding. That could also be, a key red flag to look out for. And we can treat it, especially with the breastfeeding, by supplementing hormones. So generally, this will also include a referral to endocrinology as well for sort of long-term management for these women. Okay, so question 9. Okay, so there's a lot of information on the slide, but we can sort of talk through it. So, in this scenario, the correct answer is D. So, in terms of what this woman was experiencing, it was preeclampsia. So preeclampsia, any woman who is over 20 weeks of gestation and presents with hypertension, edema, potentially nausea and vomiting and visual disturbances should always be a red flag. And typically it's classed as hypertension and protein in the urine on a urine dip. So they're at risk. And depending on how far along they are, the obstetricians might want to either probably more than likely admit the woman. There might be considerations depending on her gestation. Might be considerations for an early cesarean or an early delivery, but the only way to definitively treat preeclampsia is the delivery of the placenta. So often decisions are sort of discussed about whether or not the sort of the gestation of baby, but then also the health of mum. So Erin has sort of highlighted here a good mnemonic for anti hypertensives with managing preeclampsia. So hypertensive mums love nifedipine. So you want to start hydralazine IV with a fluid bolus, methyl dopa, labetalol, oral or IV, and then nifedipine. But you would only use magnesium sulfate if if the woman starts to develop seizures. So a bit of background, this was a case that Aaron actually saw during his general surgery night shift. So there's a pregnant woman, she was about 33 weeks. She was very unwell. She was massively overloaded and very edematous. Nifedipine was started, but it was starting to be refractory. So critical care ended up getting involved because they were just querying when to start labetalol, which is second line. She ended up responding. I think Aaron said he was with her for about over an hour, but he felt like it was the longest hour of her life because that's when she started responding. And he saw her in the canteen 3 weeks later, post delivery, walking around. So I think that was a bit of like a full circle moment for him. But yeah, he just wanted to kind of share this share this very sort of scary but interesting case with you guys. And then question 10. Oh, okay. So the answer is option E. So prescribe metronidazole twice a day for 7 days. So we'll go to the next slide. So the patient presents with bacterial vaginosis. So it's caused by an imbalance of the pH in a woman's flora. Generally, how it's diagnosed is the presence of three of the following. So, sort of homogeneous grey-white discharge, a high vaginal pH, so more alkalitic than acidotic, fishy odor when potassium hydroxide is added to the discharge on the slide, and clue cells seen on microscopy. So generally this can be diagnosed sort of straight away in the lab. It doesn't need to be sort of sent away for testing. The same for thrush as well. So patients can go in, get swabbed, seen under the microscope, and then they'll get sort of a diagnosis there and then. Management for some patients, if they're asymptomatic, normally doesn't need any treatment because again, it's caused by an imbalance of the pH. You can offer some advice about reducing exposure to sort of contributing factors such as smoking or vaginal douching and the use of antiseptics, so sort of bubble baths or bath bombs or shampoos or any kind of scented creams or lotions in the vaginal area. If a patient is symptomatic, that's when you would offer antibiotics such as metronidazole, like we've already discussed. And there is an option. So if a woman prefers not to take metronidazole, but would rather take like a topical treatment, or for whatever particular reason they can't tolerate the oral antibiotic, you can prescribe intravaginal metronidazole gel once a day for 5 days. But generally that can be be used as off-label for younger patients as well, or intravaginal clindamycin cream as well. To be completely honest, I don't think I've ever seen, or so far in practice, I've seen anybody opt for the intravaginal option. Most people would take the metronidazole. just another thing to advise, you've all just to be aware of, we've always taught, you can't drink on antibiotics, but this is the one antibiotic that you actually can't drink on because it contains the active sort of metabolite, contains the same sort of substance. I can't remember the name off the top of my head, but it basically induces, it's normally what alcoholics or people who suffer with alcohol dependence might be used as well, in terms of the same active chemical. And it can basically induce like projectile vomiting, so it can make patients really, really poorly. But that is some sort of counselling to be aware of as well. We've finished a little bit early. I think I might have flown through that. I'm sorry, guys. But yeah, thank you for joining the session. Any questions at all? I'm just going through the chat now as well. Any questions, just post them in the chat. Also, there's another thing to note about bacterial vaginosis. So recently, over the past year or so, there's been sort of papers that have talked about whether or not bacterial vaginosis is actually an STI, or if it's an STD, sorry, an STI, or if it's not. And I think that's because from reading, some papers have said, well, like I mentioned, it's the change in pH, but people who have new sexual partners can, or sometimes often, report episodes of having or experiencing bacterial vaginosis after that. So there's kind of like a hot topic debate going on at the moment, but currently still in the UK, it's not considered an STI.
Yeah, I was going to say, just at the moment, it's people often ask you and ask if their partner needs to get tested or anything like that. It's not generally considered to be transmitted by sex, even though sex can trigger it. Also, because specifically if they're having, I mean, it's also common in women who have sex with women, but if you are a woman who has sex with a man, especially after ejaculation, sperm changes the environment because sperm's alkaline, so it'll kind of reverse the environment. So that's why, and especially a new partner as well, there's something about that which just changes everything, and it can take some time to get used to. But yeah, it's very interesting. So I've sent out the feedback already. We've got our last session for this final series next week, which is on sort of similar leaning into sexual health and reproductive things, which I'll be doing with one of my colleagues called Sophia. So please join. It'll be really fun. It's a topic I'm really passionate about, so please join. And yeah, any questions, let us know. If not, we'll end the sessions in 1 or 2 minutes time. And I hope you guys enjoy it.